Hi everyone, my name is Jessica. Today my presentation will be on female orgasmic disorder found in the DSM-5 under sexual dysfunction disorders. Let's jump right into some diagnostic criteria. We have 4 symptoms that we need to be paying attention to when diagnosing women with this disorder. First, we need to be looking if symptoms are experienced almost all or on all occasions of sexual activity. There can be a marked delay in frequency or absence of orgasm altogether, or there are orgasms periodically, but they have reduced intensity. Criteria B states that the symptoms in criteria A have occurred for a minimum of 6 months. C, symptoms create great distress for the individual. And D, symptoms are not better explained by a non-sexual mental disorder, and they are not a result of distress in the relationship, such as physical altercations, and not attributable to the effects of substance use or other medications. There are some specifiers that we need to look at, such as lifelong. Has this been persistent since the individual has become sexually active, or is it acquired? Has it occurred after a period of relatively normal sexual function? It can be generalized. It's not limited to the certain partners or situations that the woman has had, or opposite, it could be situational. It is only with certain partners and in certain situations. Number 5, under any of these circumstances, has she experienced an orgasm? Or it can be mild, moderate, or severe. Less in frequency, usually in the middle, or severe. Other factors that we need to keep in mind are partner factors, the dynamic of their relationship, who they are to each other, individual vulnerability, how the woman feels about herself. Is she a confident woman? Can her self-esteem be better? Or relationship factors. If the two partners are in a romantic relationship, how does that look for them? What is the dynamic? The course and prevalence state that female orgasmic disorder varies widely in women from 10% to 42%, depending on factors such as age, severity, and duration. Estimates may not consider feelings of distress. In fact, only a few women report distress due to a lack of orgasm, and 10% of women never experienced an orgasm in their lifetime. But on the other hand, women have reported experiencing orgasms with age. With age, women become more experienced with sexual activity and knowledge about how their bodies work. They can determine what works for them and what doesn't, using things such as masturbation. When they have higher consistency with having an orgasm rather than engaging with a sexual partner. They get a chance to see what they like, so when they engage with a partner, boundaries and expectations become clear. In temperamental prognosis, women may feel anxious during sex. Sex is a very intimate situation, having concerns about judgment from the partner or the narrative getting out to peers and how they may feel about their partner or the situation at hand. And then pregnancy. Pregnancy can very much result from unsafe sex, and women can also have that in the front of their mind while trying to enjoy it. Environmental, there could be a strong association between relationship problems, mental health issues, and orgasmic difficulties, such as sociocultural factors, and such gender roles can influence the experience of an orgasm. Women were probably raised and society taught women that sex and women have to look a certain way. Genetic, physiological prognosis relate more to pain during sex, such as multiple sclerosis, pelvic nerve damage, and vulvovaginal atrophy. These all equate to vaginal dryness, itchiness, or pain during sex because of a decreased estrogenization of vaginal tissue. We must also consider cultural considerations across women and how sex and women and partners and romantic situations look different across the world. Women differ in difficulty experiencing orgasms, or even the importance they feel regarding if it's even important to their sexual satisfaction. Most women never orgasm and never report it because they see nothing wrong. The female distress scale for U.S. women showed that 43.1% of women have experienced a physical problem during sexual activity, 72.8% in African women, 17.7% in Northern European women, and 42.2% in Southeast Asian women. With these statistics, you can see that female orgasmic disorder is not specific or rare to certain women on a global scale. In any disorder, it started somewhere. So let's get into some history. Female orgasmic disorder made its debut into the DSM in the 1980s as psychosexual dysfunction. What this focused on is highlighting psychosocial issues as the important link to sexual problems. How women are feeling about themselves and their partners was at the forefront. Women began to find it difficult to identify their orgasm because it didn't seem as easily noticed as ejaculation in men, which happens almost all the time, and it's extremely clear that it happened. Pressure of women experiencing orgasms began in the late 1920s with something called marital adjustment. Marital adjustment was the thought that men had that they felt their partner must have an orgasm to be a proper sexual encounter that made them sexually compatible. And women began to feel as though the natural aspect of having enjoyable sex and reaching a natural orgasm has been taken away from them. Their sole purpose was to please the man, and that couldn't be done if they did not physically orgasm. There were some theories that scientists decided to put out when they began thinking, such as Whelan in 1980, that cognitive distortions began to arrive in women with female orgasmic disorder. They began to feel like they could be labeled by men, by their peers, if they had many sexual partners or not enough experience. And that's how stigma arose. Black and Loveless in 1987 began thinking, negative thinking began to positively correlate to negative sexual experience. Women worried about negative judgment from both partner and peers, and negative perceptions about themselves. If sex went wrong, that meant that they felt unworthy of being with men, or men felt that way about them. So the pressure was kind of at the forefront rather than having an enjoyable sexual experience. Most women who suspect that they may be suffering from female orgasmic disorder can visit their GYN to get something called a pelvic exam. Their GYN will check their patient's pelvis for genital thinning, which is related to pain during sex, that can interfere with reaching an orgasm. But even more popular than a pelvic exam is a self-report tool. Usually these are in the form of self-administered questionnaires, event logs that can be presented to a therapist or a counselor on how sex went for them, and daily diary or journal entries regarding feeling towards sex. So what went wrong can be deciphered and see what steps can be taken to fix it. These are some self-report tools that are extremely popular. The three that are arrowed are the ones that are mostly used and brought up in the DSM-5. In all disorders, we have to be careful because disorders can very much look like one another. So in female orgasmic disorder, we have to make sure that we are not diagnosing a woman who has a non-sexual mental disorder such as depression, which can usually look like diminished interest or pleasure in everyday activity. Substance use can also explain orgasmic difficulties. Interpersonal factors such as relationship stress, intimate partner violence, where that involves physical altercations, and other sexual dysfunctions such as sexual interest or arousal. Most importantly, we make sure that we do not diagnose a woman with female orgasmic disorder if the patient reports inadequate sexual stimulation. That is something that attributes to the two partners' relationship dynamic and not a disorder. Here are some treatment options that can be given to women with female orgasmic disorder. One of them is the therapeutic route. 2 and 3 and number 5 are either antidepressant or hormonal medications that a woman can take to help with this, or increasing clitoral stimulation, which involves another thing that the two partners must do and come to an agreement with each other. So let's get into our case presentation and try to dissect this. This is Mariah. Mariah is a 28-year-old South African woman. She has lived in the U.S. since she was 18 when she came here to pursue her undergraduate degree in public policy against her parents' wishes. They raised her to believe that her job as a woman was to grow up, marry a rich man, and take care of the house and children. During her last year of college, she began dating her now husband, Jay. They have been married for 2 years. Even though Mariah is happily married, she reports having sexual issues, being that she has never reached an orgasm. Her husband is the only man she's ever been sexually involved with. However, it is not the same for him. She worries that he is not satisfied with her as he might have been with other sexual partners. She has enrolled in her local gym to try to drop a few pounds to see if that will help with her confidence. When she tried to talk to Jay about it, he responded, "You just have a lot to learn about sex." She has colored her hair, spent $400 on a new wardrobe, and told her husband that she is interested in using sexual devices during intercourse. He declined. So, as far as symptoms, we see that there are some cultural differences in how Mariah was raised. Her parents put more on her romantic pursuits and how she was taken care of rather than her pursuing a career for herself. She is also dealing with being with a man who has had other sexual partners and she has not. So like we discussed in previous slides, female orgasmic disorder can come as a result of experience. She may not know what she likes during sex, but her husband Jay does know. So in that, they might not be compatible to each other in regards to communication. Speaking of communication, this was his response when she went to him with this problem. "You just have a lot to learn about sex," which can diminish her confidence. And back to what we were saying about experience, she does not know a lot about sex, so she can also be feeling very insecure when she's with her husband. She might have physical appearance issues, which comes to the invulnerability that we talked about, the individual invulnerability, being that she had to color her hair and she spent $500 on a new wardrobe just to be appealing to her husband or maybe just appealing to herself. She can also be dealing with anxiety or depression, being that she's a newlywed, came to this country from somewhere else, and she's having trouble having sex with a man that she's supposed to love and love her back. And if we could go back and remember the culture-related issues, Mariah is from Africa, where 72.8% of women that live there have trouble having orgasms during sexual activity, and that is way more than half of the women. And Jay also declined her invitation to do other things during sex that might help her orgasm. So there might be some distress in the relationship and personal distress. So I would definitely say that Mariah has female orgasmic disorders, but she also should definitely report distress. And she might want to seek having therapy with her partner as well, being that she sees this as something that can potentially ruin her marriage and her self-esteem, and her husband does not feel that way. I would love to hear any thoughts that you guys have on this case presentation so we can decipher it and discuss. And here are the references that I used to complete my presentation. I really do hope you guys enjoyed. I really enjoy learning about this topic. It's something that I never really got into before, but it's very interesting and I'm looking forward to seeing further research. I hope you guys enjoy the rest of your semester. Good luck on everything.